If I didn't mention probably one of the greatest mental health advocates and humanitarians that this country's ever had, that's a former First Lady, Rosalynn Carter, who just passed away, as all of you know, yesterday. And I believe she was the first former First Lady to testify at a congressional hearing on mental health. So she has been a champion on this issue for so many years. So if we could have a moment of silence for her, I'd appreciate it. Great, thank you. We are incredibly grateful to Beth Israel Lahey Health for sponsoring today's program. In particular, I want to thank Melissa Schuyler, Vice President of Government Affairs, who not only serves on the Council's Board of Directors, but is also co-chairs our Healthcare Committee. As some of you may be aware, Beth Israel Lahey Health has recently expanded into the Granite State, having acquired Exeter Health here in New Hampshire earlier this year. Before I hand it over to Melissa to introduce our guests for the first half of the program, I wanted to take a moment to quickly remind you of some other upcoming New England Council events. Needless to say, we've had a very, very busy year. If you came to our annual dinner, there was 1,800 people. Our chairman indicated that between the first quarter of 22 and the present here in 23, we've had 100 in-person events all over New England and in Washington, which is extraordinary, to say the least. And we have not taken our foot off the gas at all. We'll be right back here at the New Hampshire Institute of Politics, December 1st, for Capitol Hill program with Senator Jeanne Shaheen. We'll be back in Boston. We'll be hosting events in December with House Minority Whip Catherine Clark, Congressman Richie Neal, and Congressman Jim McGovern. One of our most popular events of the year, our annual holiday celebration, will take place at the John F. Kennedy Presidential Library on the evening of December 14th. And then we'll wrap up 2023 with a very special program on December 18th, looking at the affordable housing crisis here in New England and its impact on our region's economic well-being. The program will feature keynote remarks from Senator Elizabeth Warren. And as always, you can find more information and register for all these wonderful programs on our website, or you can scan the QR codes at your table to visit our online events calendar. But today, we're very fortunate to be joined by two of Capitol Hill's most steadfast champions for policies that will expand access to mental health and help prevent and treat substance abuse. New Hampshire's own Senator Maggie Hassan and Representative Annie Kuster. To introduce them and the moderator of the first session of today's program, I am pleased to introduce Melissa Schuyler, Vice President of Government Affairs at Beth Israel Lahey Health.
Jim told me not to do anything troubling up here. Good morning, and thank you, Jim. I'm Melissa Schuyler, Vice President of Government Affairs for Beth Israel Lahey Health, and I'm really glad to be a part of this conversation with all of you this morning. I do just want to take a minute for us to recognize our colleagues, our friends and families from Concord Hospital who make this conversation even more important. So we know there are so many issues. It's representative, I think, of why so many of you are in the room. We really want to take a minute to recognize what those friends, families, and colleagues are facing. And what I'd like us to do is to take a minute to put some of our energy, our effort, and our conversation into how we'll address those issues together in this room so that we don't have to see more of that, so they know the supports are there for them. I know in this room we can do that. At Beth Israel Lahey Health, we are so proud to be a part now of New Hampshire with Exeter Health Resources coming into our family. We're privileged to take care of residents of New Hampshire for so many years. We're looking forward to doing that now, to taking care of all of you, to taking care of your families, your employees, and to working with you in the days and the years to come to shape what that healthcare looks like. Across BILH, behavioral health has been a core function for us for so many years, for our founding institutions, and it became a focal point for BILH as we became a new healthcare system in 2019. Whether that's in providing care through our emergency departments, embedded psychiatric care in our primary care departments, short and long-term substance abuse recovery centers, or in places like the Heart House, where we provide support and treatment in a, in a group housing setting for mothers in recovery who are trying to rebuild their lives with their kids. We're also working like heck, as so many of you are, to try to expand and grow the workforce in behavioral health in so many different ways. So I am so thrilled that we're here today to hear from Senator Hassan, to hear from Congresswoman Custer about their unwavering support in this field, to hear from some of the other organizations who are on the ground that at Beth Israel Lahey Health, because we know we can't do this alone, and neither can we meet all of the needs, to really deepen some of the partnerships with amazing organizations, whether it's our payer partners and whether it's some of the other amazing organizations who can help us get that care and treatment out into where our families and our communities need it. We have been so excited to continue to grow and build on this. I think everyone here today comes at this work. It's our advocacy work, it's our policy work. For a lot of people here, it's the work on the ground, actually delivering on the front lines. And so many of us, I think, come here with a deep personal impact on behavioral health and understanding what it does. But we also come knowing what comes with that, what gets alleviated, the stress that is taken away from a family, the pain and suffering that can be removed when you can connect, whether it's a one-time consultation, whether it's an inpatient acute treatment, whether it's a long-time journey in the healthcare system. But when we can bring those, we know we are helping families. Every one of us has seen that make a difference. I'm so glad to be able to join this conversation, to have everyone in this room joining in that conversation, because it's the light, it's the ground we'll make together. I'm really pleased to be able to introduce Dr. Neil Meehan, who at BILH and Exeter Health Resources we're lucky to have on our team. Trained as an emergency medical physician, he has seen the most acute of circumstances and how it impacts patients and their families. As the Chief Physician Executive at Exeter Health Resources, he's helped our organization and many others really lead and lean into places that we say, oh, you know what, we're doing this. But he's really pushed our leaders to say, actually, let's talk with every one of our physicians. Are they providing the assistance they need? Are they pushing into the space that we can make them a little bit more uncomfortable, but it's going to be good for them, it's going to be good for our patients, it's going to expand access. And through the New Hampshire Hospital Association, he's helping to lead other organizations in that space as well. Dr. Meehan, we're very thankful for your expertise, for your dedication and your passion. We're so happy to have you lead this conversation with some other great leaders in this space. Thank you.
All right. Thanks for inviting me, and I appreciate the opportunity to be here. My name is Neil Meehan. I'm the Chief Physician Executive of Exeter. I spent most of my life as a physician at Lawrence General Hospital, where I saw where healthcare fails, and we really see where the safety net fails in a lot of other places, and the commonality between Lawrence and Exeter and Worcester, where I also worked, is that we've seen behavioral health be one of the most common and probably the most devastating illness that has so many facets to it that fail. And so, we've been inundated with all kinds of new behavioral health issues that have come up since the pandemic. And at any time, any one of our ERs could have at least 3/4 of our beds filled with teens, even preteens who have behavioral health issues such as anxiety, depression, suicidal ideation, substance use now, things that we never saw before, at least not in the numbers we've seen before. And these children will spend not days, not weeks, not hours, but months in a 12-by-12 room where they'll celebrate their birthday, where they'll go to school using some teleeducation, et cetera. So I also have some lived experience during this time. My daughter was stricken with a pretty serious behavioral health disorder. And although we're still in recovery from that, the challenge was immense, nothing I ever expected. And even though I come from a family that has the means, and I have a two-parent family, And I also am in medicine, so I can navigate that. The challenge was unbelievable. So I just want to put that in perspective, or my own perspective, when I talk tonight. So I want to introduce Congresswoman Custer, and I want to introduce Senator Maggie Hassan to the stage. It's so great to have you here. And although I don't have a civics degree, I'll make some mistakes. I hope you cut some slack for me tonight.
It's okay.
Nice to meet you.
It's okay, we don't have medical degrees.
Make sure everybody's mic is on. There we go.
Testing 1, 2, 3. We're good.
All right. Great. Nice to meet both of you, and thank you. So I told you a little bit about myself and some things I'm going through, both at work and at home. I know both of you have been unbelievable advocates for mental health, behavioral health, substance use disorder. This is probably for both of you, but what drives you? What gives you the passion to do what you do in such an environment up in Capitol Hill?
Go first.
Sure. So when I first started running for Congress, I learned, this was in the early days when the opioid epidemic was hitting New Hampshire. I remember going over to Keene to a family group, and even at that time in Concord, you would never have heard heroin, and suddenly I'm in a room full of families with no place to turn. There were police, but there was no structure, nobody, there was just the individual families that were on the front lines of these drugs that were coming in and just following the pattern of the interstates. So Vermont was hit very hard, and then up 91, Lebanon, Claremont, Keene were hit very hard. And so as soon as I got to Congress, I come from a family that's been very involved in mental health for a long time. My great-grandfather and my great-great-grandfather were psychiatrists at the New Hampshire Hospital back in the day where we didn't have the treatment and the medication and all of that. And so I knew I wanted to get involved in this, and as it spread across the state, in my second term, Frank Ginta came back to Congress, and I was talking with him about putting this together. And so we created the bipartisan task force on opioid addiction. Now it's mental health and addiction. And so for the past 10 years, that's what I've been focused on. And what's interesting, later, in the midst of all of this, and I can share with you our agenda, we put out agendas of bills that are bipartisan in the House and put together packages like the Support Act that the senator will get into. But I was quite along into this when my own brother out on the West Coast, he's now 72 years old, and he had a series of hip surgeries, and they had him on both OxyContin and oxycodone from September to April. And by May, we had to intervene and get him into a treatment program. And so we have been living this for the past 5 years, and I've just been out there to visit. It's a really challenging journey, and he lives with my nephew, who is 54 years old with late onset schizophrenia. Oh, wow. And so these two bachelors are trying to make a go of this life, and I can just be compassionate and be helpful and try to track down resources. I finally hooked him up with a doctor that does Suboxone, and the most recent visit, things were better, but my heart goes out to you and your family and all the families that are dealing with this. It's very challenging.
Thanks.
And I appreciate you sharing your family's experience, and Annie, you sharing yours. I also have family members who have struggled with behavioral health challenges. But I think I'll start my answer by saying my first day as governor, my first appointment was with advocates from NAMI, New Hampshire, because I had been talking throughout the campaign and throughout my time in the state Senate with families who had loved ones with mental health issues and had no place to go. And the state had been sued by constituents with mental illness, and we settled that suit and tried to set up a system that could begin to provide the kind of infrastructure that we need to have an adequate mental health system. Then, a year and a half into being governor, we began to see not only heroin overdoses, but fentanyl overdoses at a level that was pretty unique in the country. And I have been to funerals of in families where the second adult child has died from a fentanyl overdose. I have talked to parents who have lost twins in one night at a high school party. And so that has been a real driver for me. But I also think the thing that is important for us all to recognize, and we have made some progress, but the progress we have made starts with the fact that people with mental illness and their families, people with addiction and their families, have voiced their concerns and their realities in a way that has finally allowed us to address the stigma that has been attached to mental illness and addiction for so long. And I think back, and this memory was just triggered for me recently. When I was maybe 8 or 9 years old, the phone rang in our house, my mother answered, and the voice on the other end of the phone, I don't know who it was, one of her friends, said that one of her closest friends in our home community had just died by suicide. And I remember my mother's gasp, I remember some tears, and I remember that we hardly talked about it again. Fast forward to June of 2017, when I participated as a senator now in front of the New Hampshire State Library of the dedication of a statue of former Governor Gil Winan. Yeah. Who you may or may not know, and if you haven't read Citizen of London by Lynn Olson, you should. It tells the story of his life, among other things. But Winan was governor. He was hired by Franklin Roosevelt to be the first commissioner of Social Security. He was a Republican, Roosevelt was a Democrat, but Winan was somebody who believed in reaching across the aisle. And then he was our ambassador to Britain during the Blitz after Joe Kennedy was sent home. And yet he came back. He had gone to St. Paul's School, and he died by suicide in 1947. And at first, St. Paul's wouldn't take his remains for burial. They eventually did, but nobody had heard of Gil Winan. Think of all that he did because he had died by suicide. I keep that notion front and center because the reason we have made progress is because people in treatment for addiction have come up to me as governor when I was surrounded by troopers and said, here we are in recovery, and they're basically saying we matter and we count, and that's how we make a difference, and that's why we've made some progress, but we've got a lot more to do.
Wow. So I can tell you from the front line, the top 10 reasons we're in this situation is stigma. Yeah. So I'm glad you mentioned it. So thanks to your leadership, we have made some recent progress over the years, and I was wondering if you could tell us what you've worked on in recent years, and what do you see the impact having been so far?
No, you go
Okay,
with the supporter.
so there are a number of things we've worked on. I would start by saying passing Medicaid expansion. The fact that the ACA established expanded Medicaid and provided for coverage for mental illness and addiction in that bill, the fact that we were able to get it across the finish line in a bipartisan effort in New Hampshire made a huge difference, and we have been building on it ever since. The SUPPORT Act, which we passed in 2018, dramatically increased resources to communities all over the country to build up the kind of treatment and recovery infrastructure that we need. In New Hampshire's case, that resulted in a 9-fold increase in funding. Now, we got to reauthorize the SUPPORT Act. it expired at the end of September. We have more work to do in terms of building up workforce and giving the system a sense of stability and sustainability. And we can talk more in further discussion about some of our efforts to do that. The other thing I will point to right now is the establishment of the 988 hotline, national hotline that provides 24/7 voice on the other end of the phone for people in mental health crisis. Latest data says that the average wait time is under 40 seconds to be connected to a live person, which is obviously critically important.
So this is the agenda that we put out every year. This year it has 70 bills, but they're all bipartisan, and we usually bring them together into packages, and the SUPPORT Act, the original SUPPORT Act, and now reauthorizing the SUPPORT Act is part of this. And our goals have to do with access to treatment, obviously, first and foremost. One of the issues that we're doing a great deal of work on right now is telehealth, particularly in rural communities like New Hampshire, where people would have to drive 2 hours over the mountain to get to the treatment. I first saw telehealth in mental health when I was on the Veterans Affairs Committee, and I was up north in Gorham, New Hampshire, and there's a veterans center there, and these guys were coming in, and they were sitting down in a comfortable chair with a potted plant and a television, and they were talking to therapists at Dartmouth-Hitchcock. And I was so amazed and how effective it was. And then I had my own personal experience after January 6th, and I was one of the last members in the House side to get evacuated, and it was a very close call. We've now seen the video that it was literally 30 seconds from when I was evacuated with 3 other members to when those insurrectionists were in that hallway. And afterwards, I had to deal with my own PTSD. I'd never experienced this, and it's cumulative from previous traumas, et cetera. So I had, from our employee assistance program, an amazing therapist. And at the time, I look back on it, I was very skeptical. I assumed that you would need a video connection. It never occurred to me that you could do this by audio. But it was better for me and easier for me to do it that way. And it was phenomenal and very, very successful. So now I'm a huge proponent of telehealth and working hard to make sure that audio only is an option for people, particularly in rural communities, but older people that just can't cope with working with a computer or don't have a computer. So that's one piece. The other big piece that we're dealing with right now is workforce, and I think all of you understand that. New Hampshire has a 1.7% unemployment rate. I think it's actually the lowest in the country. And what we've learned is with healthcare workers, and particularly workers in mental health and addiction and co-occurring illness, but we have some good programming going on, and we've got a pathway, sort of a ladder, if you will. In New Hampshire, you can come out of high school with an LNA degree. We've got good healthcare programs in our high schools, and then our community colleges have good programming, and we've been increasing the funding for teaching in the health professions, nursing and mental health. And then our 4-year colleges, increasing those programs. And one of the very rare silver linings in this whole world of opioid addiction is that people, both for alcohol and for drugs, if they have their own lived experience and have success in recovery, that they're very interested in going back and getting the training to become a part of that workforce, and obviously very effective at it. So I'll just add from the big picture, when I was a girl growing up in Concord, New Hampshire, the New Hampshire hospital where this shooting happened last Friday was right down the street from us, and there were 3,000 people inpatient. And now that's down to 300. My mother was a big part of this, Senator Susan McLean, and actually Chris Sununu's father, John Sununu, was the governor. And it was a model for the whole country that we deinstitutionalized and we sent people back to the community where they could be closer to home and family. But what we never did was to adequately fund the community mental health that they needed in their communities and the support systems that they needed. And we may get to it on the next question, but when I talked to the people down in Nashua about the rise and the situation, they brought up housing as a very, very important component. And we also have a really tough situation in New Hampshire, a 0.1% vacancy rate. A healthy vacancy rate is 5%.
Yeah.
You cannot find a place to live. And so when people end up in congregate housing with despair, it turns out to be a bad combination. And so we need to tackle this all across these issues: workforce, access to treatment. And then our group also works with law enforcement, and we'd probably get into this later, but literally criminal chemists in China trying to stay one molecule ahead of the FBI. So we can, it's a big topic.
Yeah. You mentioned telehealth, and right now part of my daughter's treatment involves folks from Los Angeles, folks from Vancouver, someone from London, someone from right here in New Hampshire, all running a team. And I just, also I know that, COVID has really accelerated that. Can you just mention some of the things you're thinking around telehealth, specifically either IT or?
Part of what we'd had to do, this issue is on some days just plain overwhelming, and on other days just frustrating. So I'll just give you a couple of examples where I had these aha moments. And I should say, for those of you who knew him, I worked previously with Dr. Alan Green, the head of the psychiatry department at Dartmouth. And he was the one that originally taught me about co-occurring illness. And there's a huge issue. For 50 years, we have missed the boat in the quote-unquote war on drugs, in that 50 years ago when Medicaid was created, we had an exception for people during incarceration, and you lose your coverage the day you walk into the county jail, the state prison, the federal penitentiary. So multiply that out, 50 years, 50 states, with no treatment, not access to treatment for either the mental health or the substance use disorder. And then people come out and we all act shocked that they go back to their drug use. We're not shocked they still have diabetes, but somehow we're shocked. And so one of the things that we tackled early on, and we're still in the process of, is how to get treatment to people when and where they need it. The one thing they have is time, and so it turns out you can make an incredible difference with the intervention of access to medically assisted treatment, access to therapy, and give them the supports that they need. The same is true out in the community. Yeah. And so telehealth can really help with that, because it means you don't have to have those resources, those personnel on payroll. You can use telehealth from other parts of the country that don't have 1.7% unemployment. And again, that other issue about audio only is a big one. Access to broadband is something we had to take on during, COVID was just sort of a wake-up call. And I think for anyone in our generation, I don't know how long the medical community would have gone with doctors saying, no, we can't do that. Of course we can't do that. And then suddenly, Friday the 13th and Monday morning, that's exactly what everybody's doing. Oh, you can do this online? I remember talking to a doctor, and he was like, this is unbelievable. Totally changed my life. Yeah. And I think it took that to jumpstart the idea that we could do it this way. But there are barriers along the way that we have to keep chipping away at.
And I think I would add a couple things. One, I didn't mention in my initial answer on some of the things we've done, and it goes to workforce, and it also goes at some level to the telehealth issue, especially around addiction. We passed the MAT Act, which is stands for medication-assisted treatment, which, as you all know, is the gold standard really for treating substance use disorder. What that has done with the president's signature on the bill is go from 150,000 people nationwide who were authorized to provide medication-assisted treatment to 1.8 million, because now everybody with prescribing privileges across the country can automatically prescribe medication-assisted treatment. That is a force multiplier. Of course, it still leaves a lot of work because people have to get trained in addiction medicine generally, and it's a complicated population to bring into your practice. So we're going to have to help with those things. But it has also raised the issue as the COVID waivers for telehealth are expiring, kind of what's the right combination, right, of in-person versus telehealth prescribing and practice. And there is one school of thought that says we saw so many more people able to access addiction treatment and mental health treatment because of the waivers for telehealth that we don't really need to require in-person appointments at all. And then there are people who say, well, there's some balance here. It depends a little bit on the patient, a little bit on the nature of the illness. So while we are sussing that out, because there's some research and data coming, a lot of us are trying to lay the groundwork to make sure we continue authorizing telehealth in these critical areas, but also figure out what that right balance is. And I know we look forward to working with all of you because we got people who actually do this work in the room, and we got to figure that out. But I do think that there is enormous bipartisan recognition of how useful telehealth has been, especially now. This is the plug for the infrastructure bill. Why does infrastructure matter? It matters for a whole lot of reasons. But boy, getting high-speed internet to every corner of New Hampshire just makes a huge difference for healthcare, especially around telehealth in these areas.
And being an emergency physician who's lived through the last 25 years, getting the X waiver and MAT into the hands of primary care physicians, emergency physicians, what you've done and what we've done together has been revolutionary in how we can now basically create access for those. So I know we could talk about that all day, but boy, that is
well, and I should just
quite an
add,
accomplishment.
one of the most powerful proponents of getting rid of the X waiver was the special permission you needed from DEA to prescribe buprenorphine, among other things. You could prescribe opioids without a special waiver, but you couldn't
Like candy.
But you couldn't prescribe the treatment for opioids. And it was an emergency room physician from MGH who, at a press conference, basically told the story of a patient who came in. She had overdosed. She needed treatment. He did his research. He wrote it all up. He went to his attending, and his attending said, "Oh no, we don't do that here."
Yeah.
She has to go to some sort of rehab or recovery center. And here was this young resident in the ER saying, what do you mean? I know what to do. I've just spent this much time researching it. She's my patient. And the fact that now emergency rooms will be able to give people the medication and get them started is really important.
Yeah, we've stigmatized the treatment at some point, and now I think we're on our way to undo that. I wanted to go back to the Support Act because, to be frank, I didn't realize how much was in the Support Act. And I'm not sure everybody is completely informed about that. And if I'm not, I'm assuming there's others. But it is also something that I think I've seen the direct benefit as a provider. I was wondering if you could talk a little bit more about the Support Act and what it contained, maybe, or just a high level.
I will start, and then so the Support Act was passed in 2018, bipartisan recognition that we had a nationwide opioid epidemic, not just opioids. We had a substance misuse epidemic in the country, and as we have seen, it's been heroin, it's been fentanyl, now xylazine is coming into the picture, methamphetamines are an issue, and obviously alcohol is an issue. And so what the Support Act did was really focus on getting enough resources on the ground to build up the kind of infrastructure that we need to treat substance use disorder, which obviously with co-occurrence that Annie mentioned, means also treating mental illness. One of the things I worked really hard on with Senator Shaheen in the appropriations process was making sure that the formula for distributing funds under the Act weren't just done on a population basis, because we were one of the hardest hit states in terms of overdose deaths per capita. And I wanted a formula that recognized where the epidemic was taking the hardest toll, which states needed the most help. And that was an important thing for us to be able to get the level of funding we did. We now have to, as we're improving, we are, I think, no longer in one of the, I shouldn't say top 10, worst 10 states for overdose deaths, but we're still up there, and we want to be able to sustain this. So the Support Act included that kind of funding. Over the course of, I can't remember precisely whether it was all passed at once, but we also made sure, for instance, that people needing short-term residential treatment who were on Medicaid, because of course, again, Medicaid expansion provides for a lot of the treatment here, could go to residential facilities that had more than 16 beds. That's something I'm trying to make permanent moving forward in the reauthorization of the Support Act. I've got a Republican co-sponsor with me. There are a lot of other pieces to this, but I think the thing I would also ask people to consider is, as Annie referenced, this epidemic is evolving. And as we see more and more treatment stood up, as we see the destigmatization of addiction so important, we are seeing transnational criminal organizations change their behavior to try to find markets for fentanyl in different ways, or xylazine, right? So one of the things that I just got back from a bipartisan trip to China, you heard President Biden and President Xi announce an agreement to work together on the precursor chemical traffic from China to Mexico to the cartels made into fentanyl and into the United States. That part of that effort was our bipartisan delegation. We met with President Xi and his cabinet to really focus on this. So this new reauthorization of the Support Act has to do a number of things. It has to increase and sustain and increase funding. It has to deal with workforce issues. So Senator Murkowski and I have a bill that would expand a targeted student loan repayment program for people who, professionals and paraprofessionals who go into addiction medicine. It has to deal with the changing nature of the criminal organizations who are really flooding the country with xylazine and fentanyl. So Senator Cornyn and I have a provision that would allow federal grant money to be used to buy fentanyl and xylazine test strips. So important to know what people are getting. And then Senator Blackburn and I have a bill that would make coverage of substance use disorder permanent in Medicaid, because that authorization expires, I think, in 2025. So we want to make sure that the Medicaid coverage continues for that. So that gives you just some of the ideas. There's a lot there, and as Annie mentioned, I can talk about this for hours and hours, and I'm sure Annie can too.
Well, I won't go into all the details. Just suffice to say there are 70 bipartisan bills in the House version of this.
Yeah.
And most of our staffs are working very closely together. So most of them are coordinated between the House and the Senate.
Yeah.
We passed our bill in July in the House Health Subcommittee and then in the Energy and Commerce Committee, so we're just waiting to bring that bill to the floor. The reason that I do this in such a bipartisan way is to make sure we can get this to the floor. You may have read that we're in a hyper-partisan era, and this is one of the rare issues that we continue to work together on. I often say this is a challenging issue, but at least there's not a pro-heroin lobby.
Yeah.
And so, but I think we've covered most of it. It's getting rid of these barriers to treatment, like the waiver and that type of thing. It's increasing access to treatment, particularly, as Maggie said, the medically assisted treatment, that the, best in practices in terms of how people. I think we went for such a long time in this field, just with this sort of this approach to it. Just you've got to try harder. You're not trying hard enough, and kind of a deprivation approach. I can say, just from personal experience, that's hard to do when you're trying to eat less. I can't imagine when you are addicted to a substance and everybody around you is just saying, yeah, you've just got to stop that. You've just got to try harder. And I think recognizing, so part of it is actually about research and getting as much research on treatment as we have in research on the underlying pain medication, and trying to learn more, both as practitioners and as policymakers, about that connection of co-occurring illness. And one of the things that I've become much more aware of is that the people are self-medicating for various conditions that have happened in their life. And I remember going to the women's prison right before COVID, so I need to go back. It's been a few years. But I was so struck by the fact that 100% of the inmates in our women's prison, I call them patients, had either 75% were survivors of sexual assault in their either childhood or youth or adulthood, and 25% were abuse and neglect in their childhood. And so I've been very focused. I ended up starting a whole new, different bipartisan task force to end sexual violence, because I think there's a connection to trauma. And I think COVID and what you're describing, this new wave among youth, it's a different kind of trauma, but it was tearing you out of your social networks. And the internet generally, I can't even imagine being a teen in this period of time, because the focus on how you look and how you present yourself, and it's such an sort of out-of-body other experience. When I was a girl growing up in New Hampshire, we were hiking and skiing and horseback riding and out in the woods and just learning to be a person. And then, of course, we went off to high school and had similar things, but we weren't trying to live some life that was curated online as being some kind of perfect situation. And so anyway, a lot of this is tied together in trying to understand access to treatment, the workforce issues, telehealth issues, and the research to inform us. And that's why we try to stay in such close touch with all of you, is that you're the ones on the front line that can help us navigate, what do you need? What is it that we can do to help? And just realizing that Maggie's on the front line in the Senate, I'm on the front line in the House. We're first in the nation, trying to do this work. And it's very challenging, as it is for you every single day and night in the ER.
So I think we have time for maybe one more question. Is that right? You mentioned partisanship, and of course, I think we're all focused on that around the country. And given that there's funding issues and partisanship is as high as ever, we've just seen the struggle to get a new Speaker of the House. So given all that, and it is an election season, what are you up against or optimistic about coming up into that milieu regarding behavioral health and all that you're trying to do to get this legislation through. Can you tell us how you're going to find common ground, or how do you want to speak to that?
I mean, I'll start, and
Yeah.
then, in the Senate, they have to get to 60, so that's even harder. We have to get to 51, or 51%. No, I mean, that's why I approach this work in a bipartisan way, because seriously, there's not somebody on the other side, other than my Republican colleagues wanting to spend less money. But what was interesting, when I first started this and when I first created this bipartisan task force, I would go up to my colleagues on the floor and I would say, do you have a heroin problem? And they'd be like, no. And I said, no, in your district. And they would, in the beginning, they would say to me, oh, we don't have that. Yeah. And I'm like, really? Because I'm pretty sure you do, but you don't know about it yet. But, now there is not a district in the country where this is not in the top 5 or top 3 issues or the number 1 issue in their district. And so I have a lot of colleagues from places like Kentucky and West Virginia and, Southern Bible Belt red districts that I try to work with. We don't agree on a lot, and if you were to line up our voting records, this may be the only issue that we come together on. But it's a really important one. We're all there because we have compassion for our community and we want to help people. And so I just try to meet them there. One thing, and I'd love to hear your comments, Senator, is I think we also need to not be knee-jerk defensive on certain issues. And by that I mean the law enforcement issues are very real.
Yeah.
And we can't have it both ways, not supporting law enforcement and hoping to solve this problem. And so coming up, probably in the next few weeks, is a big issue about the border and about fentanyl coming over the border. Now, a wall is not going to stop fentanyl from coming over the border because a drone can get fentanyl over a wall or a plane or anything else. But there is technology, it exists, we have it, and it's not being effectively deployed at the ports of entry, which is where it's coming through. When the cars and the trucks, and I saw a photo from a colleague of Laredo, Texas, and he was on a Zoom, but behind him was this bizarre photo. I'm like, what is that? And it was all the trucks lined up at the port of entry every day going through. And I've been there, and I've seen the cars that are ripped apart trying to find heroin and cocaine. Now, fentanyl, like trying to find fentanyl, it's the grain of salt. Like, how are we going to stop the flow? But we can make that a bipartisan issue. Yeah. We do not have to be defensive on that issue. We need to cut through some of the rhetoric. It's not primarily coming through with the people. It's coming through by the truckload or hidden in the trucks. And, let's try to find some common ground in the next couple of weeks on that issue.
No, to Annie's point, there is huge bipartisan support for investment in treatment and recovery because, as we all know, these illnesses strike people from all walks of life.
Yeah, that's the other thing.
And, this was the other thing when I talk about the evolving nature of the crisis. I was also in Mexico this year talking to Mexican leadership, including the president, about their role in combating cartels that are primarily responsible for fentanyl and now xylazine coming into the country. And for a long time, when I did these trips, I was in Mexico in 2018 making the same case. I was in China in 2019 where we got them to agree to crack down on fentanyl. They would say to me, this is an American problem. Mm-hmm. Nowhere else in the world has this problem. It's because you guys overprescribed opioids and you let your corporations oversell and lie about opioids. And you don't have enough treatment in healthcare. And this is your problem. This is not our problem. Well, that is changing. Sadly, partly because our market is so saturated, but also because we have stood up treatment in a massive systemic way, and partly we have it destigmatized. And now what the cartels are doing is, and we've cracked down on dealing, and we've cracked down on the opioid manufacturers, right? We held them accountable. I still think the settlement should have been bigger, but you know, we have shut down Purdue Pharma, for instance. And so now the issue is the cartels see that, and they are now tricking people into taking their first dose of fentanyl by counterfeiting pills, right? So this is an insidious transnational criminal problem, and it's beginning to impact other countries because they're looking for bigger markets. So we have to Annie's point, not only deal with the healthcare priorities here, we also have to warn our young people and their families that you cannot buy drugs on the internet, which is where a lot of young people are being told this is Adderall, it'll help you settle your nerves. This is something kind of harmless, and it turns out it's laced with fentanyl. And so one, we have to do that kind of public education, and I hate to scare people with this, but I have met with families who have lost loved ones because somebody said this pill will help calm you down, and it turned out it was laced with fentanyl, and the person who gave it to them didn't know it. Mm-hmm. Partly, we have to deal with the border, not only the southern border, but northern border, and I will say, while primarily most of the fentanyl we seize is at the ports of entry, there is evidence that the cartels are using human trafficking as a way, in some cases, of getting drugs over the border. So we're going to have more personnel at the border actually doing what they are supposed to do, which is instead of having our agents processing people in detention centers, we actually have to have them looking for drugs at the ports of entry with technology, but also in between. And on the northern border, we have some challenges because the cartels have also realized it's relatively easy to get a visa for somebody to go to Montreal and then come down here. So we've got a number of challenges. The good news is there's technology that can detect fentanyl, that can detect xylazine. We know how to deploy it. We got to deploy it, to Annie's point, more effectively. We've got to be smart about the way we deal with human trafficking and that role in it. We've got to continue to fight the demand side here at home, and all of you are helping us do that so effectively. We treat mental health better. We are less likely to have people self-medicate, which is obviously a piece of all of this. What gives me hope is the young people of New Hampshire and around the country. So 2 stories. It is the spring of 2021. It's like March. Schools are reopening. I go to the Epping School District. They have had hybrid learning most of the pandemic. They've done a really good job of kids coming in. If somebody gets sick, everybody goes to remote. But they did a really nice job of keeping human interaction going. And I'm meeting with a group of students who start with first grade, go through high school, administrators, teachers. We're talking about how they're doing a year into the pandemic, and now there are vaccines. And I'm kind of trying to get at how kids are feeling emotionally, but I'm a baby boomer who grew up with mental illness being stigmatized, right? So I'm kind of tiptoeing around it. How are you guys feeling? Do you feel like you have enough friends? Can you tell people you feel sad? And the young girl who's maybe 10 goes, "So Senator, what are you doing about mental health?" And I found myself, I was like, okay, boomer, get over this. And that, you know, that they are focused, they're worried about their friends. And then Laura Lee Godfrey, who is a young woman who I honored recently because she has started pushing for education of young people about mental health. She was driving one day with one of her good friends, and her friend had a panic attack. And Laura Lee pulled over, but she didn't know what to do. Yeah. Now today we could say call 988, but she really wants to make sure that young people know what to do and understand this is the health issue that it is. And so when I have a 10-year-old in Epping and I have Laura Lee telling us we're not letting this fade off the radar screen, We understand what this is, and we're here to fight it, and we're here to get better. That gives me enormous hope that even in a divided Congress, even when I need 60 votes in the Senate to get over anything, pretty much anything, over the finish line, we're going to get there because our constituents advocating in a democracy the way they should are going to help us get better. And if I have one finishing note to say, and I'm looking at my team because they know I'm supposed to be somewhere else, but I just want to point out that we make progress on this because we are a democracy. And we are at a time when democracy here at home and democracies around the world are being threatened. The only way we continue to make progress on this, when marginalized people are being harmed because of stigma, is by speaking up and insisting that your elected representatives stay accountable to you and to the people you serve. And I don't want to overstate this, but we really do have to double down on the value of democracy. We can solve anything as Republicans and Democrats with some differences in approaches if the democratic system is here to make it possible to have debate and find solutions. And some of our best solutions in a democracy are creative ones that come out of that process. But this democracy has to hold for us to be able to make this progress, and it's up to each one of us to make sure it does.
So
and I think any of us who have lived any amount of time know people that have died by overdoses and suicide, and so this is us, not someone else. And it's exciting for me and others who have been in the field for a while, because I think for many of us, we felt like voices crying in the wilderness for much of our careers, and in the last few years, it's been exciting to have many other voices join us in trying to do something. I want to thank, it's exciting to have this panel here. It's fun for me because many of the people on the panel and their organizations are not people that I'm familiar with. And I think it's become exceedingly clear that it's easy to see what other people aren't doing in mental health and addiction, but that focusing on what other people aren't doing isn't getting us where we need to be, and that what we really need to do is take stock of the assets of each of our organizations, academic, private, community mental health centers, hospitals, any federal, state, community level, and sort out what do we have, each of us, that we can bring to the table, and then how do we work together to turn towards this crisis, because we really can't do it without each other. We need each other as a community working on this. So it's fun to hear from people from different angles. I did arrive back from Nairobi this weekend. I was at a conference for how do you promote mental health in low and middle income countries. It was incredibly exciting to hear what people are doing in Pakistan and in Kenya and South Africa and other places in the world where people have less resources than we have here. And yet one of the messages from the conference was that that we do have a lot of untapped resources because people care about each other, and that we can figure out how to organize and use the caring that is in our community, that we can do a lot more than we're currently doing. One of the other messages was that we have this opportunity to provide care, to build out the workforce, and to create new knowledge and understanding in our field. But another function that we have that's really important is that we have the opportunity to promote hope and bring hope to each other and to our communities. So I really thought we'd start by having our panelists introduce themselves just briefly, and then, since we're in Thanksgiving week, when they're sitting down with people they haven't seen for a while and talking to them, what is one or two things that are top of their mind as we shake ourselves off after acute COVID and look to the mental health and addiction situation? What are one or two things that seem like really big challenges, and then one or two things that bring hope at this stage? And Jill, do you mind starting?
Sure, yeah. Hi, everyone. Okay. Let me adjust. How's that? Okay. Hi, everyone. I'm Jill Borelli. I'm the Vice President of Behavioral Health at Point 32 Health, which is the parent organization of Harvard Pilgrim and Tufts Health Plan. I'm also a social worker by training, and before I did this, I worked in the field for many years. So as I think about COVID, and I've said this in many settings, the silver lining, I think, of where we are now relative to COVID is that at Thanksgiving tables, people are talking about mental health and substance use in a way that never has been, I think, in our culture. And so the stigma, although still real, is starting to shift and move. And so I feel very hopeful that this is part of regular conversation, because mental health and substance use is part of the human condition. So it touches all of us. And I think the more we talk about it, the more we can think collectively of how we address it.
Thanks very much, Mary.
Is it working? All right. I'm Mary Brunette. I'm a psychiatrist. I'm an addiction psychiatrist. I'm a professor at the Dartmouth Health and Geisel School of Medicine at Dartmouth. And I also am the medical director for behavioral health within our Department of Health and Human Services. So I just want to say my comments today are not official comments of either organization. They're my own observations and thoughts. COVID was so challenging, and I was just amazed at how people came together to really deliver health care during the pandemic. The innovations that happened were remarkable and amazing, and the communities came together, which was a real silver lining for me, seeing partners all across New Hampshire come together, meet regularly, work together to solve problems, and those partnerships are continuing. Our organizations' connections have been strengthened, so that's been a silver lining to me. The other real challenge was, how do we get people the care they need? And as Annie mentioned, telehealth. You know, people never thought it could be done, but, you know, snap, we did it. And all of the infrastructure really was there, and the science behind delivering behavioral health care via video conference as well as digitally was already there, and we got pushed to implement it. So that also, in my mind, is a real silver lining. So there's lots to be thankful for, and I'm glad to be here.
Good morning. My name is Georgia Maharis. I'm the Senior Vice President of Policy and Strategy at Bi-State Primary Care Association. The Bi-State indicates we're in both Vermont and New Hampshire, so clearly today in New Hampshire. And we work with federally qualified health centers that provide comprehensive primary care, behavioral health, MAT, oral health services in both states. When thinking about kind of coming out of COVID and looking to Thanksgiving, I'm the parent of 2 teenagers, so condolences accepted along the way. But really the difference from when even my kids were in elementary school and how you didn't talk about the services that they might need, to fast forward to now, post-COVID, where my kids both can get telehealth services, my kids can do in-person services. My high school has like 4 different programs, depending on where the kid is and what they want to tap into. So I think yes, we still have stigma, but also the fact that it's okay to talk about, and it's okay to talk about at these very intense, very emotionally driven family and friend events is a real nice opportunity that wasn't there 5-6 years ago. Thank you.
Hi, everybody. Thanks for having me. My name is Holly Mintz. I am a pediatrician by training, and for the past 5.5 years I have served as Chief Medical Officer of Ambulatory Services for the Elliott Health System. Part of my big motivation to move into this role, and it was very difficult for me to give up my practice, but part of my big motivation was to help to expand behavioral health services across our network. I'll start with, what gives me hope. I think that in light of things that have occurred over the past 3 to 4 years, I think we have a lot of opportunity to think innovatively regarding how to treat our patients. As an example, you heard the Congresswoman and Senator talk about workforce challenges, and at our system, it has in the past taken about 60 plus days to even get an intake to get to services. And we are now working with other organizations to help to cut that number down to within a week of time. And you can imagine if you're able to access care 2 or 3 months sooner, how much better outcomes you could have. And I think my message for Thanksgiving is that I recall when my children were little, and I would get home from work and I would have 9,000 things to do because the kids just got home from school or daycare, and I had dinner to make. And my little one at the time said, she was telling me about something, and I would look at her and then get back to doing what I was doing, and she said, Mom, don't move your face. Mm-hmm. And so I think my message for everyone is, when we're seeing our loved ones and talking to our loved ones, to be really intentional, because there are so many distractions and everybody's looking at their phone because their phone's buzzing. So it was such a big lesson for me to hear from my, probably at the time, 4-year-old, don't move your face, really be intentional about listening to the ones that you love.
That's wonderful. Good morning, I'm Lori Sustek, the Director for Mass, New Hampshire, and Maine from Youth Villages. I represent here today our children's behavioral health and mental health space. So in the state of New Hampshire, Youth Villages provides intensive in-home family-based services called our Interset program. And we also work with young adults who are aging out of foster care in our LifeSet program. Also thrilled I got the Burgundy memo for this morning. That's exciting. When I think about challenges post-COVID, I think we'll sort of get into that. We do intensive in-home work. We're still in the homes, and we see ourselves as an alternative to residential group care, psychiatric care. We worry every day about youth that are unnecessarily stuck in hospital boarding, maybe ready to transition to residential care. And so what gives me hope is we have great partners with the state of New Hampshire, DCY, DJJS, around providing more preventative work, more work ahead of the hospitalization, ahead of the need for residential care, to provide the family the right service at the right time, and excited about that work ahead.
Thanks so much. So I was introduced, but I'll just say I went to college at Dartmouth and then came back as a resident in 1985. So I've worked in New Hampshire as a psychiatrist since that time, in community mental health, and for a while as interim chief medical officer at New Hampshire Hospital, as well as overseeing the clinical services for Dartmouth Health, and I've been chair of the department for the last 3.5 years for Dartmouth Health and Geisel School of Medicine. So I've been in the thick of it, have a lot of friends across this state, and I think we have an opportunity. We're a small state. We can work together to make things really happen, and I'm excited about the next few years with the increased understanding of how important these topics are, that if we pull together, that we can, I think we could be in front of the nation. So we have that opportunity. So I really hope that we do it. So at Dartmouth, our new president, Sian Beilock, is quite interested in mental health. As you may have seen in the news, she had all the the surgeon generals up to Dartmouth, and our current Surgeon General, Vivek Murthy, is kind of incredible. He's so inspiring. But one of the topics he's been really interested in, besides loneliness, which I think is important, is youth and youth mental health. So, Lori, with that happening, what does that focus on youth mental health meant? The social media and loneliness, and how do you think it has an impact, and how does it affect your work?
Yeah, that's a big question, and I think has a big impact. I think reflecting on interventions like telehealth, I think that with the youth that we serve, Youth Villages, we never left the field. We felt even in the thick of COVID, it was important to be in the home, to be responding in person. Sometimes we would do outdoor sessions, we would meet on the front porch, we would be really flexible. But in terms of loneliness, one byproduct is things like self-harm or suicidal ideation or domestic violence or substance use can be hid, from a telehealth screen. And so the importance of being in the home, being, as Rep. Custer was talking about, the remote regions of the state, to be there and to be there in person. And speaking to your point, You know, when a referral is sent to youth villages, we like to admit within hours, not months, not days, right, with the capacity. And so I think about, you know, our workforce challenges, expansion, but, you know, I think initially I was reflecting on telehealth.
That's great. You know, I really, I'm in the camp that sees telehealth as being incredibly helpful. I mean, we
Yes.
did go from, you know, about 5% of our services, outpatient services, telehealth, to maybe 90% in like a week or 2 weeks.
Yes.
So it was kind of incredible. And you have some benefits of home visit by telehealth. You see them in their home environment. But on the other hand, I think that we connect humanly much more effectively together. I'm glad we're here together, you know, the informal conversations. But in evaluating people, it's really, you get more information in person. So I think there is some mixture that is really important. That's my view.
A mixture is wonderful. You know,
Yeah.
also with snow in New Hampshire, we can still do sessions if
Right.
the snow would prohibit us from being there. And, you know, I think it can be a healthy balance. When you work with the young adults, 17.5 to 22-year-olds, they like a mixture, you know. They like to be seen in person, and then they like the break. So I think the flexibility that we've talked about that this has brought forward is wonderful.
That's great. Mary, so in Kenya, one of the things I learned about was that some parts of Kenya have become uninhabitable due to overheat and drought from climate change. And there have been some very highly publicized suicides of farmers who've lost all their cattle and livelihood. The whole thrust of care and the low, you know, depression is actually the #1 disabling condition worldwide, and almost 6% of all deaths worldwide are from alcohol. So these are really important topics and getting a lot more attention, you know, in the international realm. But one of the ways to reach more people is really through integrating mental health and substance use with primary care and other health care. And so you described your many key roles in our state, and how do you see these issues of climate change and care integration playing out?
Okay, that's easy.
Well, I know you can do it.
I can. Well, so some of the innovations that have been going on in our country include integration of care, and integration can facilitate dealing with the problem of workforce in several ways. It also can facilitate improvement in the quality of care and perhaps containing costs of care. And it also can be targeted to special populations. So I'll talk about a couple of things that Dartmouth Health has been involved with, and some that our state community mental health centers and federally qualified health clinics have been involved with. So integrated care, one form of integrated care might be primary care taking on treatment of people who have behavioral health conditions, and Dartmouth Health has really been leading the charge on that in New Hampshire. So they've been implementing what's called collaborative care, and that's a model of treating behavioral health problems in primary care, in which the primary care providers take a population health approach. They screen everybody who gets care for common behavioral health conditions. And then among those who have a condition, they're offered and provided behavioral health care, primarily by the primary care provider, who has consultation and support from behavioral health experts. This is an evidence-based model of care. It's been shown through research to work really well, and it enables helping a lot of people in a place where they're used to going. You're used to going to your primary care provider, you're comfortable with your primary care provider. So it makes a lot of sense, and it's cost effective. So, so that's really important, and it's important for policymakers and insurers to figure out, okay, how, are we providing payment appropriately for that? Another kind of integrated care that's a little more novel, that's been being piloted in New Hampshire, I'm going to call reverse integration. And so rather than behavioral health happening in primary care, we're bringing primary care to specialty behavioral health settings. So in our community mental health system, in New Hampshire and all across the country, we provide care for people with serious mental illnesses or disabling mental illnesses. And people go there for care, they're comfortable going there for care. and they go there usually for long periods of time. But they don't do so well accessing primary care. So instead, we're bringing primary care on site into community mental health settings. And so that's why I'm calling it reverse integration. And the idea there is that people are attending to whole health. This mental health, actually, you need physical health to have good mental health. You need good mental health to have good physical health. So in this case, we're helping people who are really, they're used to tackling their mental health, but they let their physical, they might neglect their physical health. We implemented this program over the last 5 years in 3 communities, Manchester, Nashua, and Dover, with partners of community mental health centers and federally qualified health clinics who did a wonderful job implementing this program. And we enrolled about 800 people in this program. And what we found was that if you make primary care happen in a place that's easy to access, and you coordinate care well, get people really talking to each other, people will go. So almost 100% of our enrollees went to their primary care provider, not just once, but multiple times, and addressed problems that had been neglected. And what we found, surprisingly to me, was this shockingly large reduction in emergency room utilization for both mental health and physical health, and a dramatic reduction in utilization of inpatient beds. You never see things work out this well, but this is what happens. If you make access easy and you coordinate care, people will use appropriate outpatient services and get better so that they don't need to go to the emergency room and their problems don't escalate so that they don't need inpatient care. So everybody does better and gets better care in settings that are more appropriate and less expensive. So hopefully insurers and our regulators and our legislators will pay attention to this and think about how can we appropriately compensate outpatient care providers who do this. This care is a little more complex. There's more coordination, so reimbursement needs to match that. And it's worth it because there will be dramatic savings in reductions in emergency room and hospital days. And people are happier because they're getting care in an outpatient setting that feels better. So these have been exciting and positive activities. In our reverse integration program, I really wanted to focus on transitional age youth and young adults because I've been aware of national surveys in our country where an increasing number of youth and young adults have endorsed poor mental health. We've been talking about it all morning. I've been surprised and just not clear, why is this? And I have a 23-year-old, so I have a personal investment in trying to understand what's going on with our youth and our young adults. Why are more people endorsing? I really think it's important for us not just to be thinking about treatment, but to think about the underpinnings of why things are happening in our country and in our state. So I've tackled this research literature and in the last couple of years been reading a lot about this, and what you see is national, is it okay if I keep going on this?
Yep.
What you see in national surveys is the proportion of people reporting poor mental health started to go up in 2012. And it gradually rose and continues to rise now. There was a blip of worsening during the pandemic, but it started way before the pandemic. And so what was going on in 2012? Well, smartphones saturated our market in the US, and social media also became the norm among all ages, teens and adults. So I read the literature. Is this bad for kids? Is this bad for young people? And I think there is research supporting that indeed, having a continuous feed of information that could be upsetting and worrisome in your face constantly, in fact, is harmful for some people. Not everybody seems to be disturbed by this, but maybe a third to half of young people report, this is bad for my mental health, and there's some evidence that the way they process this kind of news is harmful. Same with social media. This constant, for those of you who use social media, the constant comparing yourself to others seems to be harmful to some people, the way they process that, but not everyone. So there's things we can do about this. So with the integrated care, we targeted young people. We wanted to help young people develop practices and skills for managing their whole health, physical health and mental health. We could think about public education in our schools, in our overall health system, or in general for parents, families, and children. What is healthy use of these devices? What is a healthy amount of being on a digital tool? We all know it's probably a lot less than what we do now. There's actually research studies, randomized controlled trials. If you simply educate people, do less, don't do it at night, and do more healthy coping, exercise, thinking skills for managing stress, social skills for engaging people in person in healthy relationships, that improves people's mental health and it reduces harmful stuff. So there's things we can do and think about along the lines of these. Now, Will asked me about global issues and climate change. National and international surveys across the world have found young people are worried about the health of our Earth and about climate. There's no disagreement among young people that this is a concern. They're young. This is their world. This is their Earth. They want to, see their future in a healthy way. So it's really important for all of us in New Hampshire, in our country, and across the world to tackle climate change if we want to improve the health of our young people, because they're thinking about it, and they want us to be working on it, and they will take action too, but we all need to get on that now. So those are my thoughts about youth and integrated care. Thank you.
Thanks, Mary. Those are all so important topics. Georgia, as you know, most people with mental health or substance use difficulty receive no care at all. Most people don't receive any care who have one of these difficulties. And of the care that's delivered, most of it is in primary care, not specialty care. It's one thing to review the research and see that it's more effective, that you can provide high quality care that improves lives in primary care, but it's another thing to actually do it. From your perspective, what will help us to increase access to high quality care and addiction care in primary care settings?
Thank you. So I think that there are significant opportunities to foster that integration that you just referenced in any way that it happens. Is it between a federally qualified health center and a community mental health center? Is it between an independent primary care practice and a hospital? But really meeting the patient where they are. So if I, as a patient, present to my primary care doctor, making sure that that primary care team has the resources to say, we can help you right now, right here. Georgia, we're going to put you in that room and you're going to be on a telehealth visit and you'll talk to the right person. Or otherwise, you know what, you actually might need a whole care management plan. So we're going to work with you and really develop that over time to make sure you're getting all of those services that you need. And recognizing that, at our health centers, we try and do as much comprehensive, whole person, population health-based care. We try and get to those social drivers of health. But sometimes we don't have the workforce to meet the need, right? Like there's only so many humans who can deliver the services. And being able to plug in, and I'm going to call on my friend Maggie in the corner and say, hey, Maggie, do you have resources at your community mental health center? Can you take Georgia because Georgia needs something right now? And I've got 3 staff who are out with COVID or 3 staff who are out with kids who have the flu. It's, I think, making sure that we're continuing to foster those connections and recognizing that it takes all of us in all instances to help the resources. And I dare say there's plenty of need. This is no place for someone to say, this is my turf, I'm going to hold it. There's plenty of need and plenty of services that could be offered. And I think the state of New Hampshire has a really lovely success story, which is, probably a decade or so ago, medication-assisted treatment was just starting to come in. And the state really said, hey, primary care providers, you need to do this service. And I can say from our health center perspective, they're like, we need to do what? Hey, what are we doing? We've not done this before. This hasn't been our space. And over time, all of our health centers are providing the service. The vast majority of their clinicians are thrilled that X-Waiver is gone. But they were already providing the service. So I think to the extent that there can be policies put in place by the administration and the legislature to say, you know what, this is so important. We're going to help you providers get the training you need to do those services. And if you'll indulge me, I actually brought a patient success story, which is why I have my reading glasses, because I want to get this right. So one of our health centers that's providing MAT services, they shared a story about a patient who entered their MAT program in September of 2021. The individual's from Puerto Rico and speaks Spanish only. Upon entering the program, she was buying Suboxone illegally on the street. The patient would have required an interpreter for all visits, but they had an MAT provider who was fluent in Spanish, so they were able to communicate with her directly. This helped in building rapport and trust between the clinician and the patient. And the patient struggles with multiple substance use addictions. She's been abstinent from opioids since she started her treatment. She currently has custody of her 2 school-aged children and is determined to provide them with a good life. And she's continuing to work with her Spanish-speaking behavioral health clinician. And to me, that encapsulates what we can do. If we're working together, we can find the right people and plug them in to help the patient where they are rather than where the healthcare system is.
That sounds great. We do need to sort out how to integrate what we do and inventory our strengths, I think, so we can really work effectively together. That's a great story. People get better with good care. I know we could talk about our own histories here probably for the whole time, and each of us has it. In my family, I've had a number of people develop severe psychiatric illnesses, and partly through being able to navigate things and help people get good care. Those family members are doing exceedingly well. Employed, married, raising kids, doing well, and you can do well with good care even when you're extremely ill. When you come in extremely ill, so Jill, I guess I sort of introduced that. We do know a whole lot about how to help people in our field. There's more to learn, but we're actually have a lot. One of the biggest issues is how do you actually get people in crisis connected. I looked you up on the internet and saw that you speak about responding to people with kindness and support. And what do you think will help us make it easier, and particularly on the insurance world, what's going to help make it easier to access great care?
Yeah, so, I often tell people that accessing the healthcare system is really hard, and I speak insurance, right? I'm bilingual in insurance and regular speak, and it is an incredibly hard thing to do. And then accessing behavioral health care is even more complicated, unfortunately. And so I think it is incumbent on health plans to really act as a facilitator to engage with members to access care. It's great when they can go to it's best when they go to their treaters who they know and trust, and they can be plugged in. But there are many, many times that people look on a website or decide they need care and haven't engaged. And so one of the programs we just have stood up at Harvard Pilgrim Point 32 Health is we now have, and this is, I can't wait till we don't need this team, I just also want to say that. We've stood up a team of people that their full-time job is helping people find care, whatever kind of care, behavioral health care, whatever kind of service that they need. And it's simply talking to them about what they're looking for, where, the time of day. And then we have our, what we call BH service navigators, go off and make phone calls. And I'm sorry to say that on average, it takes them 11 calls to find an outpatient provider. And that's average. So they might make many more calls than that, and on a happy day, fewer. But that is a lot to expect, that a person who has identified they need behavioral health will have the capacity, the time, right, to do that. To make those calls. I think the flip side of this, and I think this is really important, is the behavioral health service delivery system is taxed and filled with people who care deeply about their work, but don't always have time for the administrative stuff that comes along with working with a payer. It's critical, right? It's a three-legged stool. Payers are an important part of the ecosystem, but I think as payers, we have responsibility for making it a glide path as often as possible, like codes for collaborative care from day one. That's a very important part. You can say you believe in whole person care, integrated care, but if you're not going to pay for it, that doesn't really, that's not putting your money where your mouth is. But it's also thinking about what do BH providers, in whatever setting they are, need that's different than folks who are providing care as part of a large health system. They just don't have the resources. And so thinking about being creative about what does that kind of a partnership look like is another really important part of our strategy at Point 32 Health. We have a team, similar team, a team of folks who their full-time job is to work with BH providers. And it's really simple stuff, simple as this is how you fill out a claim, this is how you do a credentialing form, this is how you do all those things that take so much time and hours that BH providers are available. And then there's the bigger stuff too in terms of thinking about contracts and payment modalities, methodologies that really support whole person care, whether it's collaborative codes, whether it's bundled rates, whatever we can do to lift the burden from the people who are providing care, I think is critically important as part of the team, the circle, in the BH ecosystem.
That sounds great. I know from my own personal experience, the thing that makes me the most crazy of anything and want me to quit is when running into bureaucratic obstacles that take up my time, when I just want to be using my skill set to make people's lives go better.
And frankly, we do too.
Yeah, right.
There's such a need that I feel like it's a really important thing we bring to the.
So that sounds like a great thing, because it really does make people's heads explode.
I understand.
Holly, I had a chance, I looked you up too and saw a great article in New Hampshire Magazine where you talked about achieving your dreams and gave your life story a little bit. And it seemed like, if I got it right, that you kind of landed in New Hampshire by accident in some ways. We're very fortunate to have you here. And we've been thinking a lot about workforce and about the opportunity we really have if we get ourselves organized, get a little funding from donors or from the state or from the federal government or somewhere to create a statewide organized training system, particularly for master's prepared people, but also we could build out our psychiatry nurse practitioner. We're already doing that in psychology training. Because I think if we attract people at the point of training and they settle in and get engaged with the fabric of life here in New Hampshire, they start to make friends, they have kids, they start to get connected, they're going to stay here. And I think we're small enough and organized enough that we could do that. What do you think about that idea, and is that something you'd want to work on with us? And what do you think about workforce?
Yeah, I would love to share my thoughts. So I grew up in the state of Washington. So I'm a total transplant to the state of New Hampshire. It was a very random event for me, and I was planning on being here for 3 years, and I've now been here for 27. I have been fortunate to be in the field of pediatrics all those years and work for the Elliott Health System, which, as many of you know, is a not-for-profit, community-facing organization, mission-driven in the city of Manchester. We are not a big academic center. We don't have research funds. We are very, very focused to serving the needs of our community. And we, as a not-for-profit, have a very slim margin every year where we try to reinvest all of anything that we're able to reinvest back into our community. I'll share with you that, listening to other people on the panel, the workforce challenge and the sustainability of that is a really big challenge. So, we have talked a lot about integrated behavioral health models. I had one practice that I had an opening for an integrated behavioral health worker that went unfilled for more than 2 years. And in addition, if I were to try to put a behavioral health consultant in every one of my primary care practices, it would be unsustainable for my organization, and there are all kinds of other care that we would not be able to deliver. So it's been really challenging for me in this role to understand how to meet the needs and meet the workforce needs. We do have to think about other ways of doing things because, again, even though, and I've attended a lot of seminars about the integrated behavioral health model, and I think it is a wonderful model, our primary care providers are totally and completely overwhelmed. And in addition, when people need a higher level of care, there's a complete lack of workforce. So my understanding is at Manchester Mental Health, they have 65 openings. So when we have a patient who needs a higher level of care, even beyond what we can meet at our behavioral health clinic, it's almost impossible to refer them and get them care. And so what happens is our primary care providers are trying to manage these very, very complicated patients by themselves with very little help. We wouldn't tolerate that for heart disease. We wouldn't tolerate that. We don't tolerate that for other behavioral health illnesses, for other illnesses other than behavioral health. So there is a sustainability issue because, again, even if we were able to hire, even if there were 60 behavioral health workers that our organization could afford to hire, they wouldn't be there. So I'm probably, I'm an incredibly optimistic person. I love my role. It's very challenging, but I feel like, it needs to be a call to action for our state because we have primary care providers who are really struggling to manage patients, and we have patients who are really struggling to get access to behavioral health. And I also want to just share a story, regarding, we've talked a lot today about stigma and about, the awareness of behavioral health. I have somebody that I work with, a friend in another organization whose daughter has severe anxiety, depression, and of course, as we all know, COVID made that a whole lot worse. And so she actually needed to be in an intensive outpatient program. She was hospitalized and then was in an intensive outpatient program and missed about 8 weeks of school. And she was a senior, and so she had 8 weeks to make up of summer school, but wanted to walk with her friends at graduation. And she was told by her school district that she could not walk with her friends because she had 8 weeks to make up. Now, in my opinion, first of all, I went to college a long, long time ago, but even if you still had to do a summer course, you walked with your friends. You walked with your class. And in addition, it is truly my intuition that if she had been out for either cancer or diabetes or some other transplant issue, not only would she have walked across the stage with her friends, she would have had a standing ovation because of the challenges that she faced. And it took a lot of effort on the part of a lot of people to talk to her, the superintendent of her school and the school board, to allow her to walk with her friends. So my point being that we all have to understand this is such a big challenge, and I am completely in agreement about the challenges. I've been practicing, as I said, all these years. I saw the change happen with social media and phones, and I mean, like I said, I feel like I'm, an old timer at my organization now, and I've seen, I'm the historian, I've seen all these changes. Like, we really need to understand not only how we can incentivize people to work in this field, but also incentivize systems to be able to hire these people, to be able to provide the care. Along with the MAT, it's interesting because I have a panel of about 85 primary care providers, and it's not that they're uncomfortable managing the medication for MAT, it's that there are no support services for all the other things that the patients need. So in addition to the medication, patients need therapy, and they need a nurse navigator, and none of those things are reimbursed for. So the providers can write the prescription, but that's not really taking care of completely of the patient. So, these are some of the things that I think about when I think about, again, we need to bring people here to incentivize them to work here. We're a small state. It's a wonderful state. It's become my home. But we also need to make sure that organizations are financially sustainable to be able to hire these people and stay competitive so that we can actually bring people here.
Thank you. All that is true, and I don't think that primary care doctors are incredibly busy, and it's fast-paced and it's challenging, and the care has to work in the flow of daily work, and you have to add systems and you have to add people to make it work for primary care, and we need insurance mechanisms to pay for that, there's starting to be codes. But I don't think we're going to be able to expand care in outpatient care or in inpatient beds if we don't have more really skilled professionals to offer that care, and if we don't extend our non-professional self-help and peer support systems to engage, because and I don't think we're going to find them taking the providers from each other. I think we have to create our own. We have to build systems of trainings so that we're creating our own workforce and bringing people here, developing ourselves, and reaching back into the schools. We need an organized system to attract people into our field, not just random happens to happen. Mary, you had a comment.
Yeah. We've seen some novel programs in New Hampshire. Can I take a minute to
Yep, and then we're going to need
to because I agree with what you just say. We really need to attract people into the field. Lots of young people are familiar with mental health and substance use problems, as we've been talking about, and there are lots of young people who want to be helpers. So let's help them learn how to be helpers. One novel program, Dartmouth Health has been developing a program in our community college system to help people who have a lived experience with behavioral health or substance use to learn skills to become a peer support counselor. So that's developing a whole workforce that can be really, really helpful on both sides of mental health and substance use. Another novel program was developed in partnership between New England College and a community mental health center, in which New England College has been talking with the mental health center about challenges and finally heard, look, in your psychology program, let's help young people learn the knowledge and skills so that they can come out of college and really get a job in a mental health center, helping people with mental illness right away. So they're adapting their curriculum so that it's more practical, and they're developing a partnership to provide a paid internship in their senior year where young people can go and actually work within a community mental health center, be part of the workforce while they're culminating their learning experience. So novel programs like that, where we're attracting young people into the field, supporting them, giving them experiences that are really rewarding. It's very rewarding to work in this field. I think those are the kinds of things that are going to be really successful. So we want to keep building those.
Yeah, this is great work. It's really an honor to work in this field where you get to be with people who are suffering and make an incredibly positive difference in their lives, and to know, it's very human and you get to use your full self. It's gratifying work. People get better with good care. So I think we can attract people into our field and train them to be really effective. And I'm excited to work together to do that with anyone who wants to join me, because I think we need it. So what a great panel, all these different perspectives, lots of experience. Thank you for laying out some of the challenges, but also for the many areas of hope. And this hour went by way too fast, and I bet we could have stayed here all day with questions and answers. So thank you, everyone, for your attention. Thank you.